So the current standard frontline treatment for follicular lymphoma in US and Europe is represented by chemoimmunotherapy with either BR or R-CHOP based on two very large randomized phase 3 studies. Another randomized phase 3 study called Relevance is trying to compare chemoimmunotherapy to immunotherapy with Lenalidomide and Rituximab, also called R-square. But unfortunately, the primary endpoint, that was superiority in terms of efficacy, wasn't met. Because of this, currently R-square is not an available frontline treatment in Europe, but thanks to NCCN guidelines, can be used off-label in the United States in frontline. Our institution, there's an extensive use of frontline R-square, also because MD Anderson was one of the leading sites in the Relevance study. And we are trying to understand why a portion of patients either don't respond in the first place or have a very short duration of response to R-square. So we looked into tissue biopsies before and after R-square, and we noticed that a possible mechanism of either primary resistance or acquired resistance, it's increase in pro-tumoral tumor-associated macrophages. Preclinical studies show that in follicular lymphoma, BTK inhibition, by interrupting the crosstalk between follicular lymphoma cells and macrophages, may repolarize tumor-associated macrophages to a more anti-tumoral phenotype. So they represented the rationale to combine a BTK inhibitor such as Acalabrutinib, which is very BTK specific, to R-square as a frontline treatment with patients with high tumor burden follicular lymphoma. This is an investigator-initiated phase 2 study that I've had the honor to write, and we're, for the first time, AEHA and ICML presenting our data. Overall, 24 patients were included, and the primary endpoint was to increase CR rate that historically has been 50% with frontline R-square to 80% or higher. In terms of toxicity, first of all, we haven't seen any increased synergistic toxicity. So beyond the typical fatigue, neutropenia, and LFT elevation that we see also with R-square as a single regimen, there was no new safety signal. But what was really impressive was the efficacy data. Overall, CMR rates were higher than 90%, with a 2-year progression-free survival of close to 80%. What I would like to emphasize is that in this case, the overall duration of treatment was much shorter than the standard treatment with R-square. With R-square, based on Relevance trial, we currently give 18 cycles of R-square. In this case, was overall 13 cycles, and as pretty much virtually all patients achieved the CR after 6 cycles, we have now amended and expanded this phase 2 study to have additional 26 patients with follicular lymphoma and 10 patients with marginal zone lymphoma, where we will give overall 6 cycles of what we now call AR-square. And potentially, if we will see an encouraging efficacy outcome, we could consider to come out with a randomized study where we'll compare 6 cycles of AR-square to 6 cycles of standard chemoimmunotherapy, such as R-CHOP or BR. And hopefully this will translate in the future with an FDA and maybe EMA approval for this new immunotherapy for patients with indolent B-cell lymphoma.